We have only limited control over our health. We can control our weight by trying to eat a healthy diet and exercising daily. We can keep ourselves mentally active. Yet our lives are also dependent on body functions that operate beyond our control. Take a breath, a deep breath. Our lungs nourish our body with oxygen, and along with a blink of an eye and a heartbeat, breathing is one of the body's quintessential automatic functions.
The first experience was kind of like a gurgling, and I wasn't able to sleep, and it was a little alarming. But thinking it was just asthma and taking bronchial inhalers and things like that brought some relief, and perhaps that was just the way I would be living.
I just felt like he was just getting worse and worse, and the drugs that he was just being given more drugs and more drugs and more drugs, which was making him feel not very well. I guess, just thinking of living life without him was something really hard to even think about. To me, we're still young and we have a lot of life ahead of us, and so I just didn't want to think about having to go on without him.
Eventually, Richard, an Oregon resident, was seen by a pulmonary specialist at Oregon Health Sciences University in Portland.
And that produced real positive results. The doctor that we had up there was remarkable in her diagnosis. Immediately she recognized all the symptoms, and from there on gave us great treatment and positive reinforcement that the pulmonary fibrosis could someday be treated.
Idiopathic pulmonary fibrosis is an irreversible and progressive fatal lung disease. Gradually, the tiny air sacs of the lungs become replaced by fibrotic scar tissue. The tissue becomes thicker, causing permanent loss of the tissue's ability to transfer oxygen into the bloodstream. The inability to take in oxygen and transport it to the bloodstream has an immediate and debilitating effect on a person's energy level, muscle strength, and cognitive awareness.
Undoubtedly, because of my work, which I have been in the brick masonry trades since I got out of the Navy at an early age of 22. All those years around dust and mortar and brick dust, what have you, they believe that that is the scarring mechanism that created the fibrosis.
In about half of the people diagnosed with pulmonary fibrosis, the cause is never identified. These individuals are more narrowly diagnosed with idiopathic pulmonary fibrosis, or IPF. Idiopathic meaning of unknown cause. As Richard's condition became worse, the Oregon hospital referred him to the University of Washington Medical Center in Seattle for treatment. His case was evaluated by Dr. Jeffrey Edelman at the Lung Transplant Clinic.
When I first met Richard, one of the things that struck me was that this was somebody who really just had lung disease, and he was otherwise very healthy, and he had maintained his physical condition despite his lung disease. He had continued to work in more limited capacity as his disease progressed, but he really tried to do everything he could to maintain his health status, but also I think maintain as much normalcy in his life as he could despite his lung disease.
Typically, the symptoms of idiopathic pulmonary fibrosis include progressive shortness of breath, particularly with exertion, chronic cough, fatigue and weakness, discomfort in the chest, loss of appetite. In most cases, IPF patients are normally diagnosed in their 50s and 60s.
In January of 2003, I was coming back from a trip from Washington, D.C. on some business, and I just developed a dry cough.
You just kind of clue in to each other, and you just kind of realize, when things aren't quite right.
Greetings.
You might have hit the lottery today.
You think so?
Well, maybe. It's not for sure yet.
A pulmonologist in Anchorage, Alaska, referred Mark Wilson to Dr. Ganesh Raghu at the University of Washington Medical Center, where clinical research trials were being conducted under the direction of Dr. Raghu, an international expert in IPF.
I saw Mr. Wilson in July 2004.
He came to see me. He sought my medical attention for management of his pulmonary problem, which was fibrosis, a condition called scarring of the lungs of unknown cause. And in his particular situation, it was familial. In other words, there were more than one sibling that had his disease.
Our daughter was diagnosed with the same disease just 6 months before Mark was diagnosed. She had the same symptoms and had gone through almost identical type things where she had taken antibiotics and everything. Unfortunately, she did not have the medical support that Mark received, and she ended up getting pneumonia and passed away. So when Mark was diagnosed and we kind of knew what was going to happen, it's kind of scary.
At the time when I saw him in July 2004, he was functional in terms of day-to-day activities, and he did not require additional source of oxygen use.
Initially, Dr. Raghu recommended Mark participate in a clinical trial.
At that time, he was participating in a clinical trial that we were using new medications that are currently indicated for other diseases that seem to have some promissory hope from a biological standpoint.
There are currently no effective treatments or cure for pulmonary fibrosis. The pharmacological agents designed to suppress the formation of scarring in the lungs are in experimental phases. The treatments intended to suppress inflammation have only limited success in reducing the fibrotic process. According to Dr. Michael Mulligan, a specialist in the surgical management of end-stage lung disease, accurate diagnosis and early treatment are key.
Unlike a lot of other diseases, this has a very well mapped out and aggressive natural history. When folks get to be to the point where they've actually gotten sick enough to require a diagnosis, they have about 3 years to live.
IPF outcomes are worse than those for a person diagnosed with cancer. Pulmonologists who specialize in pulmonary fibrosis are researching ways to stabilize the disease, decrease the rate of progression, and extend life expectancy.
So that is what I did, and carefully monitored his situation with regular follow-ups, with regular pulmonary function tests, exercise studies, walk tests, very diligently every few weeks, and he would come and be very compliant with all of the follow-ups.
After nearly a year, the clinical trial medications proved ineffective, and Mark's health reached an acute stage.
And then I had to give him supplemental oxygen for him to be able to sustain normal oxygenation for daily activities. And then we started to seriously talk about lung transplantation.
Since the medical intervention within the clinical trial was unsuccessful, Dr. Raghu turned to the next option available for IPF patients who have reached a terminal stage. Mark was recommended for the University of Washington Medical Center's lung transplant program.
So we activated the full evaluation that was necessary to make sure that all his other organ systems were adequately functioning for him to be able to sustain the risks associated with transplantation.
The medical center's lung transplant program opened in 1991 with modest success for the first few years. Over time, key advances have been made in donor management, operative technique, post-transplant care, and immunosuppression protocols. And in 1999, the arrival of Dr. Michael Mulligan signaled a new start for the program. Having a surgeon dedicated to the program, available 24/7, is a crucial factor for success in a transplant center.
One of the unique qualities of being in a transplant program is that you really do develop a lifetime relationship with these folks, and you're on a journey with them.
Since 1999, the program has increased dramatically, with over 50 transplants performed each year. It's recognized as one of the best programs in the country, with patient outcomes and survival rates far better than the national average. The surgery requires a major lifelong change in lifestyle and a full commitment from a motivated patient, support from their family, and a comprehensive patient care plan coordinated by a medical team dedicated to the case. Along with transplant surgeon Dr. Mulligan, the University of Washington Medical Center's lung transplant program's dedicated core team includes a transplant pulmonologist, nurse coordinators, a social worker, financial counselor, rehabilitation medicine doctor, a physical therapist, pharmacist, nutritionist, and a respiratory therapist. That team will screen a patient's overall health, carefully evaluating the likelihood that a transplant will be appropriate and successful.
Once the lung transplantation evaluation is complete through multidisciplinary services, and after discussing in a lung transplant recipient selection committee where we discuss the pros and cons and benefits and risks, and we make a decision as a consensus of the committee to say, yes, this particular person, in this case Mr. Wilson, would benefit from lung transplantation.
To receive a transplant, a patient must be able to reach the University of Washington Medical Center rapidly when the call comes. This could mean making detailed travel plans ahead of time, or even moving temporarily to the Seattle area.
When families relocate, it means setting up another household in the Seattle area, which is very expensive and quite stressful to families to have to do that. But it really is sometimes the only option in order to be close enough to the hospital when they're called for transplant.
The much-anticipated call comes from a lung transplant coordinator, nurse specialists who are on call 24/7, and the first to receive word that a hospital has a potential organ donor.
When we think about a donor family and what they've just been through, it's an overwhelming process for them as well. And there's been some devastating event that has put them in this place where they have a decision to make about donating or not. So in our little section of the country and in our program, it's an opportunity for us to help a small number of people that we get to know very well on our waiting list, and in that bigger scheme of things help a larger group too, with both the organs that are transplanted and then tissues afterwards. So we do learn a bit about the donor's family situation and certainly what's happened in the course of their medical events. And there is just an underlying understanding and respect for what they've been through. It's an incredible gift to think that something can go on and help someone who's really at the end of their life and wondering if there's going to be another day.
I don't think that a lung transplant patient can be overeducated when it comes to going through the lung transplant process. That is definitely something that I do when I meet with patients, is to encourage them and give them the resources to learn more about transplant.
The transplant care coordinators and social workers provide a vital link between the patients, their family, and the doctors.
And I think for me, the role that I play as an advocate for patients and being able to communicate the needs of the patient, the emotions of the patient, those things to the other parts of the team is, I think, part of the success story for many of these patients.
I consider one person as the key person, without whose participation and willingness it will not be a success. And that person is the one that I give high credibility, is the patient himself.
If you think about it, there are lots of folks that are walking around with chronic diseases. The thought of having a kidney transplant is probably mentally more accessible to most of the population. The concept of having your lungs transplanted is overwhelming. And I think when people come into my clinic, even folks that have had their diseases for a long time, when they actually meet the surgeon and the reality and the immediacy of meeting the person who's going to do this, not to them, but with them, as I like to say, sometimes it washes over them and they're just knocked down.
I know, it's my privilege to do this. Are you kidding me? There aren't many people in the world that get a job like this. You get to do stuff like this. How you feel?
Excellent.
And if their family's not there to hold them up, and not only their family, but the family that is represented by the program, you can't do this. It's overwhelming. No one could do this alone. So their family presence is critical, and they have to be steady, and there has to be a mutual trust between me and the family, the program and the family, and it all has to work together.
You couldn't ask for anybody better. We've been married since we got out of high school. So, you know, she's seen the good times and the bad times, and for better or for worse, and sickness and health.
It's exciting.
Mark is in the intensive care unit being prepared for surgery. After 4 months on the wait list, a donor has been located.
I come to the realization I lived a long and happy life before I ever decided to take this path. And so whichever way it turns out, I'm happy, even though this is the ultimate thing, because I can continue to share some extra time with my family. And if all the moons and stars line up appropriately, it'll actually happen. You know, I mean, there's a lot of different facets that it won't even happen today. It could happen. Be a dry run, be practice for the next time.
Some patients experience at least one dry run. They are called into the hospital for surgery, only to return home without receiving a transplant. In this case, the initial medical data indicates the donor organ is a match. So the lung transplant surgery team has been mobilized under the direction of Dr. Mulligan.
It is so critical to get it right from the get-go. It starts before you even procure the organs. It starts when the donor is identified, because the physiology of brain death in the donor starts to do things to the lung that need to be corrected. And that ICU medicine is different than regular ICU medicine. It has special considerations. So I get the call, and then I am spending the next 12 to 24 hours doing remote critical care medicine for each donor that we're offered.
On this day, Dr. Mulligan has already spent hours on the phone with the donor hospital's surgeon and transplant nurse coordinators, reviewing the donor's medical history and intensive care data. Time is now the most critical factor. An intricate plan of action is set in motion when the lung transplant patient arrives in the ICU. An operating room is cleared, and hospital staff, from OR nurses to anesthesiology, race to prepare for the surgery. A surgical nurse gathers the containers and pharmaceuticals that will travel with Dr. Mulligan to the donor hospital.
My portion is preservation of the organs. That's my primary goal, and to make sure that we have the equipment and the medications that are needed for the procurement.
At the same time, a jet is readied and a flight plan filed. The race against time continues as Dr. Mulligan leaves the hospital for the flight to the donor hospital. A key component of the surgical lung transplant procedure is the aggressive effort to improve the donor's lung function in order to be able to recover a healthy, viable organ. In many cases, this requires traveling to the donor hospital in order to not waste any opportunity to match a donor and a recipient.
Exciting parts is knowing that you're going to be part of a transplant, knowing that you're going to be facilitating and helping someone that is terminally ill, give them a second chance.
However, the physiology of an organ donor is very dynamic and complex and can take an unpreventable turn, rendering the organs unusable.
It requires a long acquired experience with a lot of subtle insights and innate curiosity, as well as a passion for doing it, to do it right. And until I'm satisfied that it's at my standard, I will continue to do all the procurements and as many of the implants as I possibly can.
The surgical team has only 4 to 8 hours before the donated lungs need to be transplanted. Ischemia reperfusion, an acute inflammatory injury caused by a prolonged decrease in the blood supply to the organ, can reduce the chance that the transplant will be successful.
There's so much that goes into preserving that lung and doing it in such a way that you minimize inflammation. Because if the new lung goes in and it's inflamed, it will start to express proteins on its surface that will announce to the recipient that it doesn't belong there. And then you start an immunologic avalanche, so that the long-term results are compromised. And this is a very clear association between a bad reimplantation inflammatory response and a compromised long-term outcome. So you will pay for that suboptimal preservation for the rest of that recipient's life.
So we're working on removing and mobilizing the structures that are around the right lung. So you're under time constraints. We've done there, and there comes the right lung. That's out.
It's the old one. Very thick. Doesn't really compress. We've developed technique for putting the airway back together again that's now allowed us to have the lowest incidence of airway complications in the world.
Wow. Nice, fluffy, white, much larger capacity. His donor's a little bit smaller than he was, or he is. So it's just gives you an idea how badly restricted his lung capacity was.
We are downsizing the incisions that we use such that whenever possible we're using a fairly minimal approach to even getting access to do something as large as a double lung transplant. Not a videoscopic approach, but minimal incisions without a lot of bony division, and people are noticing the difference and they're quite satisfied. And you can't do that unless you're doing a high volume and you learn where a millimeter here, a millimeter there makes a difference. But we're doing enough of these now that we're broadening the exposure, and the team is growing in size, so this will be a sustainable change.
In conjunction with his surgical work, Dr. Mulligan focuses his scientific research on reperfusion injury, tissue inflammation triggered by deprivation and restoration of blood flow.
Although we know that white cells tend to migrate into the lung and elaborate chemicals and mediators that cause the damage, clearly you need to interrupt that process before the white cells are even recruited out into the tissue. We've identified a number of different hormones and things called cytokines and mediators that are released from different white cell subpopulations that govern the process. But that's sort of after the injury has already started to manifest. We're now identifying certain upstream signals that tell the body to react. And we're learning now how to selectively shut off the response to reperfusion and reventilation at a very refined level. Now we've asked the anesthesiologist to reinflate. You want to be very gentle the way you inflate this. You don't want to overpressurize or overdistend it. So applying just a modicum of pressure, you can see it start to recruit, start to reinflate. This is the anterior aspect or front of the lobe. As it reinflates, it will assume its position in the chest. It knows where to go. And we have to inspect the lower lobe so we make sure that it too is inflated. If you're relaxed and focused, that's when you're going to bring your best game. And so my team always brings the A game.
The surgery itself is sort of the center of the wheel, and there are multiple spokes that go out. And if you don't have a hub like that, you don't have a wheel. But nor does the hub do any good unless you have the nurse coordinators who help keep track of everybody, a tireless scheduler who gets everybody to their appointments on time as they go through these very lengthy and critically important evaluations, and a core of dedicated pulmonologists who have acquired a focused experience in transplantation.
Following a double lung transplant, the patient remains in the hospital for an average of 10 to 11 days. However, 7 days after surgery, Mark has already been released from the hospital, but returns for a checkup.
How are you doing today?
Follow-up visits to the Medical Specialties Clinic and Pulmonary Diagnostics continue for at least 6 to 12 months for testing and evaluation, including X-rays, blood, and pulmonary function tests.
When you're ready, gigantic deep breath in. Deep, 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 and then blast! Blow, 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 blow. Keep on squeezing, keep on squeezing.
Those follow-up visits are critical to prevent rejection of Mark's new lungs, and that is the key to a successful long-term outcome.
And then a big deep breath in.
Mr. Wilson is actually doing quite well. But I am a conservative person. I will be pleased when every patient
Good morning.
Good morning.
Good morning.
does well. And every patient lives longer than what we can presently give. So maybe I'm a little bit greedy.
This is really healed quite well.
Yeah.
It's very nicely healed up, okay?
Mm-hmm.
Mark Wilson had very few complications after surgery, and after 2 months was released to return to his home in Alaska. He will return on a regular basis to the University of Washington Medical Center to monitor his improvement. After 3 months on the transplant list, Richard Flora also had a successful double lung transplant. He and his wife vividly remember the moment when the breathing tubes were removed and Richard took his first unassisted breath.
They pulled out that tube, and And it was just like he was just born, and he took that breath because you don't know. And when you see him take that breath, it was like a miracle.
Once they take it out, it's like now you can breathe on your own and everything. It's just amazing.
Our grandchild, both of them, when we got to see them when they were like 20 minutes old, and it was so much like that, and it was hope that we didn't have before, and it was just a chance at a new life again.
Excellent, good. So what I'm doing there is feeling your breastbone to feel if I feel the bone slipping or moving at all, which would tell me that you haven't been treating this like a plate of glass, but it feels nice and stable. So you've been doing exactly what I want you to do.
Some prescription medicines are taken daily for life to ensure the success of the transplant.
Patients are on lifelong medical therapy after their transplant, and they also need long-term follow-up to make sure that their lungs are healthy, and to make sure that they're tolerating their immunosuppressive therapy, to make sure that they're not having side effects from their therapy. The transplant, to me, really marks the beginning of a long-term doctor-patient relationship for these patients. It's not only a heroic effort, but there's a lot of accomplishment or a lot of credit for that long-term outcome that really goes not only to the center, the physicians, the team, but also to the patients.
Richard and his wife have returned to their life in Oregon, but will continue to make regular trips back to Seattle for checkups.
What's that duck's name? Quacker?
Just seeing him be able to, play with the grandkids and go to the fair without hauling oxygen and worrying, do we have enough? It's going to be a nice new life, and we're so grateful.